Nursing and midwifery abortions GYNAECOLOGYx. Abortions is the expulsion of the products of conception before the 28th week of gestation/conception. Classification. Abortions are classified according to the nature and severity. Spontaneous. Induced. Spontaneous. This is abortion, which occurs on its own. Etiology. 1. Fetal causes. 2. Maternal causes. 3. Local disorders of the genital tract. Fetal causes. 1. Malformation of the fetus. 2. Chromosomal abnormalities or diseases of the fertilized ovum. 3. Poorly developed chorion villi. Maternal causes. Acute illness associated with high temperature. Women 2. Drugs taken during pregnancy to treat certain diseases. Women 3. Nutritional deficiencies, especially lack of vitamin E. Women 4. Chronic diseases associated with hormonal disturbances, heart failure, and anemia. Physiological factors e.g. stress, anxiety affects the function of the hypothalamus. Pituitary gland. 6. Infections such as rubella, syphilis. Local causes. I. Maldevelopment of the uterus. 2. Malformed uterus due to fibroids. 3. Incompetence of the cervix. 4. Trauma e.g. direct injury to the fetus or surgical trauma e.g. removing the ovum. Containing corpus luteum of pregnancy. Types of spontaneous abortion. 1. Threatening. This is preceded with bleeding, but the OS is closed and the membranes intact. It may end in inevitable abortion. Clinical presentation. The patient will present with a history of having had amenorrhea for 1-2 months, or having suffered from a disease weeks past. Slight vaginal bleeding for minutes, hours, or on 2 to 3 occasions for several days, apart followed by brown discharge for 2 weeks. There will be no actual marked pain, but the patient may complain of marked pain and lower abdominal discomfort. Nursing and midwifery abortions GYNAECOLOGYx. It can end in inevitable abortion. Treatment and management. The patient is put in bed with 1 or 2 pillows for bed rest. Blood is taken for blood grouping and cross-match in case of blood transfusion. If the patient is alarmed, anxious, and in pain, morphine 10 gm is given. Any increase in bleeding must be reported. Low residual diet is given. Aperients and enemas are avoided. If the patient is nervous, phenobarbital 16 is given b.d. Bed rest for 3 days after bleeding stops. Avoid physical and mental stress after pregnancy is established. Coitus is forbidden. Frequent emptying of the bladder to avoid urine retention. Frequent changing of a pad. Preserve products for Dr. S inspection. 2. Inevitable abortion. During the bleeding, the OS is open and the membrane ruptures or protrudes. It may end in complete or incomplete abortion. Clinical presentation. I. History of amenorrhea. 2. Patient might present when she is very weak and anxious. 3. Complaints of lower abdominal pain and backache. 4. Excessive pee bleeding with clots. D. Strong uterine contractions. 6. Presence history pointing to the cause of abortion e.g. fever trauma. 7. On vaginal examination, the cervix is dilated. 8. Some products of conception will be felt in the vaginal canal. Treatment and management. I. Admit in a gynecology ward. 2. Assess the condition. 3. Take vital signs T, P, R, BP. 4. Blood group and cross-match for blood transfusion if bleeding is brisk or if the initial HB is less than 10/DL. Then start on 5% dextrose and normal saline IV with 10 IU oxytocin. 6. Speculum examination and manual examination. 7. Tissues at the external OS should be removed with sponge-holding forceps and examined by the pathologist. 8. When in doubt of completeness of the abortion, consent form is signed for D and C to be done. 9. A sharp curette is used to ensure complete removal of the products after suction curettage, but do not do vigorous total curettage for uterine synechia, Asherman S syndrome may result. Nursing and midwifery abortions GYNAECOLOGYx is when all the products of conception are expelled. Bleeding of the same amount as at menstrual period continues for about a week after complete abortion. Treatment and management. 1. The patient should be observed for further bleeding. 2. All product of conception must be thoroughly examined for completeness and characteristics. 4. Incomplete abortion. This implies to when some products of conception are retained in the uterus and some are expelled. Clinical presentation. 1. The bleeding continues, sometimes very profusely, until the retained products are removed. 2. On BE, the OS is closed. 3. Patient can be anemic. 4. Lower abdominal pain. Treatment and management. Treatment is directed towards preventing infection, controlling bleeding, and obtaining an empty and involuting uterus. The chief risks associated with retained products are hemorrhage and sepsis. In a health unit: 1. Monitor BP. 2. Treat for shock due to bleeding. Administer intravenous fluids. 3. Give ergometrin 500 micrograms IV, even if the uterus is not completely empty, as this will reduce the bleeding, although its action is less in early than in late pregnancy. 4. Remove any product from the OS using a sterile speculum and sponge-holding forceps to allow uterine retraction and reduce bleeding. 5. The foot of the bed is raised and morphine 15 may be injected. 6. When the blood pressure is reached to a more normal level, refer to hospital. In hospital, the uterus will be evacuated under anesthetic by gloved finger, suction curette, or sponge forceps. The cervix will usually be open and will not need dilatation. B. Give ergometrin 500 microgram I, and as soon as the uterus has been emptied. C. Anti-deglobulin is given unless the patient is known to be rhesus positive. D. In some cases, in complete abortion, there may be no severe bleeding, but the hemorrhage continues intermittently for some weeks and it is due to placental polyps. The uterus remains bulky and the cervix dilated. Scan is done to confirm retained products and surgical evacuation is done. 5. Septic abortion. This type of abortion occurs in most cases in criminal abortion induced by douching or by passage of a non-sterile instrument through the cervix. Clinical presentation: nursing and midwifery abortions. GYNAECOLOGYx. If the lower abdomen is tender with guarding and the uterus is very tender on bimanual examination, vaginal discharge will be foul-smelling. ND. The commonest infecting organisms at present are Staphylococcus aureus, coliform, and Bacteroides organisms and Clostridium welchii. Streptococcus are both aerobic hemolytic and anaerobes are also often found. The most dangerous infections are those with gram-negative organisms, which may cause endotoxic shock, and those with Clostridia. The infection may spread to structures around the uterus, causing pelvic or general peritonitis, pelvic cellulitis or salpingitis, or organisms may invade the bloodstream, causing septicemia. Treatment and management. All cases are admitted to hospital. Speculum examinations is done and discharge taken for culture and sensitivity from the cervical canal. Blood is removed for culture and sensitivity. Patient is started on oral ampicillin 500 mg hourly with metronidazole 400 mg hourly. Review the treatment after culture and sensitivity of the discharge and blood. Continue treatment for at least 5 days after the temperature has gone down. In case of incomplete septic abortion, evacuation should be done, but deferred for 24 hours to allow the antibiotics to take action. Any product at the cervical area should be removed using sponge-holding forceps, and the temperature usually drops dramatically if the infected clot is expelled. BT will be required if the bleeding continues. Injection of 500 micrograms of ergometrin will be administered IM after the evacuation has been done. Cases of clostridial infection always present very ill, with pulse rate of 140/min and subnormal temperature. Severely anemic because of hemolysis and may be jaundiced. Large doses of penicillin should be administered when there is suspicion of clostridial infection. Any dead tissue should be evacuated as soon as possible. If there is no response to blood transfusion, possibility of gangrenous uterus should be borne in mind and hysterectomy is due. Hyperbaric oxygen should be administered if available. 1. Careful watch should be made on urinary output. Renal cortical tubular necrosis may sometimes occur. 2. High fluid intake is encouraged. 3. Regular vulvar toilet PRN. 4. Another dangerous complication is circulatory failure caused by peripheral vasodilatation due to endotoxins released from coliform organisms which has invaded the blood stream. Endotoxic shock. 5. In this case, Roman 4 plasma expander like 5% dextrin is given, adjusting the rate according to the response of the patient to the infusion. Nursing and midwifery abortions. GYNAECOLOGYx. Slow progressive hemorrhage takes place into the decidua and choriocystal space. The blood eventually surrounds the embryo and separates it from its attachments. Carneus mole. Clinical presentation. The patient usually notices a little blood stain discharge for a day or two between the 8th to 12th weeks of pregnancy. The breasts cease to enlarge after this, and the patient notices that the uterus is not increasing in size. Feeling of no fetal movement. Pelvic examination reveals a firm uterus, which is smaller than would be expected from the duration of amenorrhea. Immunological tests for pregnancy usually become negative about 10 days after the death of the embryo, but sometimes remain weakly positive for some weeks, causing confusion in diagnosis. Scanning to reveal the diagnosis. Management. All missed abortions were eventually expelled spontaneously, but sometimes not for many weeks. Once the diagnosis is made, the uterus should be emptied by suction curettage. Give ergot by mouth with stilbostrol or rumen-4 oxytocin 10-20 units, NS and 10-30 drops. Antibiotics to eradicate the infection. Blood for BGX match. Analgesics to relieve pain. Observe contractions TPRBP. Complications. I. Sepsis. Woman 2 hypofibrinogen. I. Anemia if abortion is 8-15 weeks. I. Habitual abortion, recurrent abortion, is sequential loss of 3 or more previsible pregnancies. It is a clinical and not a pathological diagnosis. Pathological findings include I. Congenital anomalies. Woman 2. Hydrophytales. Woman 3. Abnormal placenta. Woman 4. Implantation of the placenta in the lower third of the uterine cavity. The failure of the decidual response in the endometrium. Causes. The most common causes of recurrent abortion are hormonal abnormalities, hypothyroidism, genetic disorders, trisomy, acute or chronic maternal diseases, viral infection and disorders. Nursing and midwifery abortions, GYNAECOLOGYx. Clinical findings. There may be an incompetent cervix. Evidence of previous trauma, e.g., deep lateral cervical laceration. Partial or incomplete amputation of the cervix. Easy passage of a no 16-18F of an olive tit sound through a non-pregnant cervix. Congenital abnormality of the cervix or uterus. History of previous surgery, e.g., cervical myomectomy, traumatic or difficult forceps. Delivery, forceful or multiple D&C. A history of 2 or more abortions in the second trimester without pain, cramps or bleeding, with sudden spontaneous rupture of the membranes and passage of the fetus. Such a history is highly suggestive of incompetence of the internal cervical OS. Investigations. 1. Laboratory findings. WBC for total and differential and serological antibody titer. 1. VDRL. 2. BG and rhesus compatibility test. 3. Thyroid function test. 4. Urinary prebindiol measured during early pregnancy. 2. Radiological studies. X-ray of the cervix may show cervical incompetence. Treatment. Medical treatment. This depends on the cause, i.e. adequate diet, replacement of the missing hormones, and complete bed rest. Surgical treatment. 1. This is indicated for incompetent cervix. A Sherdock or stitch is inserted under general anesthesia. Using a vaginal route, a non-absorbable suture is placed and tied around the cervix at the level of the internal OS. 2. The patient is nursed in bed for 3 to 5 days before being discharged home. 3. Encourage her to rest as much as possible during her remaining period of pregnancy. 4. The suture is removed 7-14 days before delivery and she is allowed to deliver normally. 5. If the abortion becomes inevitable, the stitches must be removed. Advice on discharge. Avoid violent exercises, lifting of heavy things. To avoid coitus. To have rest during the period. Imposed rest when she sees the threat of slight vaginal bleeding. Induced abortion is a deliberate termination of pregnancy in a manner that ensures the embryo or fetus will not. Nursing and midwifery abortions, GYNAECOLOGYx, is induced by the doctor for the purpose of helping the mother's life who might be medically unfit for the pregnancy or not to continue with the pregnancy. Indications. It may be categorized into maternal, fetal, paternal, social, obstetrical. Obstetrical conditions prior to major uterine injury or damage, e.g. cesarean section, myomectomy, uterine rupture, or extensive perforation. Roman 2 multiparity, recurrent preeclampsia, eclampsia with its multiple hazards, severe ISO, immunization, old age. I. Surgical. Any condition that may comprise a good previous surgical intervention, e.g. correction of the uterine prolapse, VPF. Roman 2. Orthopedic. Osteogenic imperfecta, severe kyphoscoliosis. Roman 3. Cardiovascular disorders. Congenital heart disease, recurrent cardiac failure or myocarditis, systemic or pulmonary. Hypertension, aneurysm. Roman 4. Endocrine. Severe diabetes mellitus and chromocytoma, adrenal or parathyroid hyperfunction or deficiency. The psychiatric. Incurable schizophrenia and recurrent depressive manic psychosis. Woman 6. Social. Mental retardation of the mother is demonstrated by the inability to care for children, poverty, excessive family size, rape, prostitution, and incest. Criminal abortion, or illegally induced or performed. Criminal abortion is induced by use of drugs or mechanical interference or chemical. 10th. The interference is made without aseptic precaution or anesthesia. The results are always dangerous. Complications of criminal abortion. 1. Endometritis or even peritonitis may occur. 2. Perforation of the uterus, vagina, or urinary bladder. 3. Hemorrhage may be severe and sudden death from shock or air embolism may occur, or great anemia. Nursing and midwifery abortions, GYNAECOLOGYx.